So this case is on endometrial cancer, and the case is provided by Rhonda Farrell. This is about Jenny, who's a 63-year-old woman who lives in Narrabri in northwestern New South Wales. She's morbidly obese, a height of 165 centimetres and weight 165 kgs, BMI 61. Hypertension, she's got hypertension. She's on iberstatin 30, HCT 25 and amlodipine 10 milligrams. Her blood pressure is 165 on 95, but there's query about the accuracy of that given the difficulty of with applying the cuff. Type 2 diabetes, she's got type 2 diabetes and on metformin SR 2 grams daily, and on that she's still got a HbA1c of 8.5. So she's also got hypercholesterolemia, the atorvastatin 10 milligrams daily. The cholesterol now is 5.4 and HDL of 1.2. She leads a sedentary lifestyle. She's got poor exercise tolerance. She's a non-smoker and consumes 60 grams of alcohol daily. And she presents with postmenopausal bleeding for 2 months. And on curette, she has endometrial cancer. And so she's referred down to the Women's Hospital in Sydney and is assessed as high operative risk and has a Mirena IUCD inserted for 4 to 6 months to try and improve her fitness for surgery. And she's referred to the obesity clinic. She is motivated to lose weight as her mother had died recently of obesity-related illness. She declined gastric bypass surgery. This is her obesity management. She started very low caloric diet using with Optifast. She started walking and dancing. She stopped alcohol completely, was in regular contact with a dietitian and her GP, and she lost 25 kgs in 6 months. This is a good news story. So at 6 months, there was a repeat curette, and the histology showed regression of the endometrium to complex hyperplasia. Another Mirena IUCD was inserted for 4 to 6 months to continue the weight loss. So at 12 months, her weight was now 120 kgs. She'd lost 45 kgs and her BMI was down to 41. And now she underwent a hysterectomy and was found, histology showed minimally invasive or laparoscopic hysterectomy. There was an histology of the endometrium. There was no cancer. It was complex hyperplasia only. The only post-operative complication was transient atrial fibrillation due to electrolyte disturbance, probably due to refeeding syndrome. So the questions are, and Greg, we should start with you. What are the factors that led to the regression of endometrial cancer to complex hyperplasia? So let's start there.
So microphone's working now. So we commonly use progestogens. Are very effective, as we mentioned before, at reversing both endometrial cancer and complex atypical hyperplasia. So with complex atypical hyperplasia, you have that diagnosis. You've got about a 20% chance that if we did a hysterectomy today, you'd find an endometrial cancer. If you left it and did nothing, over the next 2 years, you've got about a 30% chance of developing cancer. So that is very reversible with progestogens. And as mentioned, in young women who are trying to preserve their fertility, it's a good effective thing. Similarly with grade 1 endometrioid adenocarcinoma, so that progression on, the use of the Mirena, because the progestogens are up and directly contacting the endometrium. And we'd also often add in medroxyprogesterone acetate, about 200 milligrams a day. The downside of that is it often exacerbates diabetes and it's slightly thrombogenic as well. But you couple all this in with encouraging weight loss and exercise, and it has a significant impact. So I think this is a cancer which potentially is very reversible. You're not always as lucky. In fact, we operate on a woman on Monday, 165 kilograms, incredibly poor mobility, gets around a house with a stick and has a mobility scooter, but really doesn't get out of the house. And she'd had symptoms for 2 years. The cancer had actually grown through the back of the uterus to be around the bowel. So at time of surgery, had to abandon it because it was just inoperable, and her obesity precluded any significant operative ability at all.
And Greg, could I also like to start with the second question, and then Jenny, if I could move to you in answering the second question before we come to Jerry about medical management of the weight loss. So did the weight loss contribute to the regression? Was it a factor?
Well, I think it's probably a factor. It's hard. I think we quoted from the WHI study earlier on that there is no question if you lose weight, you reduce your risk of developing a cancer. It's hard to determine how much the weight loss actually contributes to the regression of the cancer. It certainly makes the operation viable, in terms of both the anaesthetic risk, because often these patients go to ICU intubated post-operatively because the weight just means that they can't actually breathe properly.
So I was going to say, Jenny, in that when she first presented, came down from Narrabri and was sent off to yourself for advice, dancing did it?
The obesity clinic is multidisciplinary, includes psychology, surgeons, medication, dietitians, and exercise. So it would have been a combination of addressing all of those factors.
So Optifast is the...
It's one of the strategies. So if you're using calorie restriction through diet, a VLCD Optifast is an example.
What's that acronym stand for?
A very low calorie diet. So it means there's two gradings. One is 1,200 calories and the other is 800. And they're designed in the intense phase to achieve a state of ketosis. So that's where you're using fat as a primary fuel for your body. So that's one strategy that was effective for her. It takes a lot of compliance and diligence from the patient, a lot of motivation, and the full phase is 16 weeks, and then they go on to a maintenance phase. Other options that are offered from the dietary perspective for rapid weight loss would be intermittent fasting. You can do 5-2 or 16-8, and there's also evidence in whether you can do cycles of dieting, like 4 weeks on a diet, take a break, come back onto the diet for 4 weeks, and how those patterns would manifest prolonged weight loss.
Right. Now, before we go to Jerry, Rhianna, can you tell us, was it the dancing?
I'm not sure of any specific evidence in endometrial cancer and dancing as such, but I guess, as you said, combination of all of those allied health interventions and increasing physical activity in a number of areas. I guess what's important about that is highlighting that it doesn't have to be one type of activity or one type of exercise for any one person.
So what would you be saying to her with her initial presentation?
So I guess the physical activity guidelines for people with cancer, it's 150 minutes of moderate to vigorous physical activity per week, plus 2 or more strength training sessions. So I guess that's huge for some people, but in addition to that, we say that something is better than nothing and more is better than less. So finding something that somebody finds enjoyable, that comes with that intrinsic motivation is incredibly important when we're talking about choosing activities for people to do. I would have loved to see somebody like this doing some strength training. When we see people go through treatment for cancer particularly, often we see this sort of like obesogenic sarcopenia where they have a decrease in their muscle mass as well as this increased adipose tissue. And so increasing that lean muscle mass is really important. If you're very sedentary, doing anything will increase your lean muscle mass, but some strength-based training would have been beneficial also.
Especially in the context of rapid weight loss, you often see loss of muscle mass, and so an exercise program can help to reduce the loss of lean mass as you rapidly lose body weight.
Yep. So, Jerry, from the medical point of view, where does that fit into the multidisciplinary approach to managing this patient?
Well, yeah, I mean, a couple of quick points as well, I think, that have been made is that these patients who are obese might actually present a little bit later than the general population, partly due to social exclusion, not being able to get out of the house, they might be embarrassed, etc. So I think that's a really important point. The other thing is there's nothing more motivating than developing a cancer or a precancerous condition to try and lose weight. So that was obviously one of the things that sort of spurred this patient on. But now, at this point in time, if the patient is still on a very low-calorie diet or is in the maintenance phase, then really preventing weight regain is key. So activity, obviously dietary changes. And in this phase, I think some of the GLP-1 receptor agonists, such as dulaglutide, she's got diabetes, a once-weekly injection that's very simple to do would be very appropriate in this phase. And it can induce further weight loss. And I think changing the way that you induce weight loss is really important. Maybe a period on dulaglutide and then maybe back on a very low-calorie diet for a period of time, or coming off and giving them a break is really important. But at least maintaining this patient's weight loss, I think, is key, because there's a huge tendency for weight to be regained in this situation.
And the final question is, what are the long-term risks to her if her BMI remains at 42?
She's still got the risks of, she still has diabetes, and I assume that's still poorly controlled. She obviously has the increased risk of malignancy down the track of any other type of cancer. And then there's all the other psychological issues. She almost certainly has obstructive sleep apnea, which might be contributing to lethargy, so she should be screened for that. Osteoarthritis, joint pains. There are all the other complications that go with obesity need to be managed. Down the track, she might be someone who could actually be a candidate for bariatric surgery if her weight plateaus. But I think really maintaining the interest of this patient, letting them be part of a multidisciplinary approach, I think is really key. And then using drugs such as SGLT2 inhibitors as well down the track, and switching treatments, I think is really key.
Great. Liz, do you have any comments to make?
I've got a question for Greg.
Yeah, good.
Just with regards to the Mirena coil and the progestogens helping with weight loss, can you just tell us the endocrinological mechanism of how progestogens help keep weight loss down?
I'm not sure they keep weight loss down.
Keep weight, yeah.
It's levonorgestrel.
Yeah.
So it's impregnated into the Mirena and suffuses directly into the endometrium. And the advantage is also that you don't get the systemic effects of progestogen, which every woman knows is the bloating, constipation, etc., the appetite stimulant. So it's in England at least, it's contributed to a 70% reduction in hysterectomies because of control of dysfunctional bleeding. So it's been a great tool. The other thing I'd say too, as doctors who see these patients, when they do lose weight, the positive reinforcement you can give them by recognising it and saying, you look great, you've lost weight, you can just see them almost leaping out of their skin, because they really love that positive reinforcement. And I think that's something coming from us particularly, because we often can motivate them to lose weight in the first place, but the recognition of their weight loss and the effort it takes is, I think it's a huge thing that we can all contribute as well.
And I guess just one...
So a very, very key point, and perhaps other people in the audience may wish to comment about how to maintain the successful weight loss. So the motivation of having had the cancer episode only lasts so long till there's regression to the mean, and people inevitably go back to where they were. So any other thoughts from the audience about ideas that help as you are the people seeing them long term? I see a comment here.
Thanks, John. Just a question about alcohol, and it feeds into that question as well. Just asking Greg, I know that breast cancer is increased with people who ingest alcohol, and it's quite a low limit. More than 2 drinks a day for women increases breast cancer risk by about 70%. Is there the same risk for alcohol per se with this cancer, or is it just the obesity and the sugar intake? And I guess one of the things that will keep the weight off is to keep the alcohol level down, won't it?
Yeah, I think it's purely the obesity and not so much the alcohol.
And with alcohol intake, the proposed mechanism of how it increases your cancer risk, there's 2 different types. One is for mouth and throat cancer because it disturbs the mucosal lining of those organs. And with breast cancer, it's how ethanol would impact estrogen.
So we've got a couple of minutes. Any more questions?
Just a quick,
Yes, please.
quick
Liz.
comment
Yeah.
just to get about holistic care and things that perhaps as GPs you've sometimes got more of an insight into the patient over a long period of time. Obesity can sometimes impact on patients' self-esteem as a sexual being as well. And, I remember when I was a registrar having gynecological patients, they were literally pre-terminal, but they were still asking for sexual advice and sexual counselling and, immense sort of grief about that part of their life. So it's important to remember that aspect. And when we were talking about the prostate cancer case, I forgot to mention that in early prostate cancer, where men are often having a brief intervention with androgen deprivation therapy, some exercise physiologists like Prue Cormie have done some studies showing that an exercise intervention of 12 to 16 weeks helps maintain sexual function and get back to sexual function after prostatectomy and after external beam radiation. So just I guess a comment to remember about the sexual aspect of our patients.
And I had another comment to make as well. You were talking about how to maintain weight loss. Some of the simplest advice we give is to weigh yourself once per week, because coming back from a 1 kilo weight gain is much easier than a 10 or a 15 kilo weight regain. So that constant monitoring, and I know that we heard from our exercise physiologist that having simple self-monitoring tools like a Fitbit that is a step counter or a pedometer, so you've got constant reinforcement about when things are not normal and before they've gotten out of control.
So asking them to bring that in for each of their GP visits is a nice, interesting behavioural strategy for change.
Yeah, and there's many apps that you can have on your phone that give you your once a week alarm. It's Wednesday weigh day, like tell us your weight, tell us your fasting BSL and your step counts for the week.
I see two more questions, I think, before we break up into repeat sessions.
Coming from a dancing family, I know how important dancing is in the lifestyle of people who dance. And I wonder whether continuing on and just encouraging her in her dancing, maybe getting some new outfits and looking great and photographs, bringing in photographs and just praising every so often and communicating with the family, giving her some permanent interest in life through her dancing.
I think that's your question, Rhiannon.
I guess it probably ties in quite well to what Jennifer's been speaking about a lot as well, and that's certainly that lifestyle change is really most effective when people are able to set meaningful goals and that those changes are more long lasting if it's something that's meaningful to them, that motivation is intrinsic. So I think certainly trying to capitalise on any interests that they might have to help them set goals for themselves that are attainable and achievable.
Anecdotally, my prostate cancer patients who tango do very well.
Now we've got the final slide, which. Keep going. Okay, so the subsequent course is that she continues on the Optifast diet. She started a new relationship and continued dancing. And after 2 years, she now weighs 70 kgs. So she stopped her antihypertensive and diabetic medication. And she's now a spokesperson for gynecological cancer survivors. And this is a true case. So it does happen. And it is worthwhile. And on that very positive note, let's finish this session.
All right, thank the panel.
Great.